Thank you, Claudio. I'd like to have my panel discussants come up. Tom Todoran, Joe Mills, Josh Adams. We're going to have a little fun. I think we're going to see what you've learned over the last couple of days and see if you can apply it. We're going to have some case presentations. And it's going to be a little audience participation. So get your eye clickers fired up. So we're real fortunate to have some really talented people up here today. Joe Mills, who's come all the way from Arizona to join us, flying on the red eye last night. Todoran, who's one of our interventional cardiologists at the Medical University, and Josh Adams, my partner. All these young people I have learned a great deal from in a short period of time, and I've known Joe Mills a long time, and I learned a lot from him a long time ago when he came back from his fellowship in Oregon. So the child really is the father to the man. So thank you guys for teaching me something over the years. So what we're going to do, we're going to have a case discussion format with some audience participation. I'll present the case. We'll survey the audience for things that you would do or what your preferences might be. And during the discussion, there may be some things recommended maybe outside the IFU, but we'll keep that in mind. We'll then ask for some comments by the panel, and then we'll be hopefully have some time to take some questions from the audience. So I think that everybody in here knows, it's been here for the last couple of days, knows there's a plethora of options involving treatment of critical limb ischemia. You can use a vein, bypass, angioplasty, intervention, atherectomy, laser, all kinds of things are out there. And the question really is, in a practical point of view in your practice, what is the best option for these critical limb situations? So my disclosures, none of which are financially relevant. So the first case, panel and audience, we have a 69-year-old black gentleman who had right lower extremity ischemic rest pain. It doesn't bother him every night, but 2 or 3 times a week he'll wake up and has to put his foot over the side of the bed. He has diabetes, hypertension. He's been on dialysis for over 20 years. He has no coronary history or symptoms, and he's a very functional 69-year-old fellow. On his physical examination, he's got good femoral pulses, no popliteal or pedal pulses, and no tissue necrosis or breakdown, and this is his vascular lab. His ABI is 0.32 and no discernible toe pressure. So the first question for you, fire up your eye clickers. Does a panel have an eye clicker up here? Does everybody have one? You guys can vote too. Based on this clinical picture for this patient, you would recommend no intervention but optimize his medical management. You'd go ahead with a CT angiogram, or given what you know about patients with end-stage renal disease and peripheral vascular disease, proceed with offer him a below-knee amputation, perform an angio and intervascular attempt at angioplasty, or do an angiogram with plans for bypass. All right, mark your things. Let's see what looks like most people would choose D. All right. Some people, not very many people went right to an amputation. That's encouraging. Okay, so most people would recommend an angiogram at this particular time. So he was treated with Clouse for a while and actually did a little bit better. Didn't wake up at night quite as much and was able to get by and follow up and didn't really want anything done right now. But he comes back in 4 months and now he has a lesion, some tissue necrosis involving his right fifth toe. And he still has, now he's begun having his intermittent rest pain again at night. And then he did undergo this arteriogram. And I think you can see the proximal part, the SFA is patent proximally, all the way down to the popliteal. Can we get the lights down a little bit more? The people in the back of the room might be able to see a little bit better. Here you see reconstitution of a perineal artery and then a dorsalis pedis artery. So your next question. Based on this angiogram and the clinical picture, now you would recommend no intervention, better pain control, hyperbaric oxygen. Now you'll recommend an amputation based on this arteriogram. Or would you try an endovascular attempt at angioplasty, perhaps using a retrograde approach to either the dorsalis pedis or the perineal? Or would you try a bypass to the perineal or a bypass to the dorsalis pedis artery? The question is, what's the quality of his vein? And he has a visible great saphenous vein all the way down to the ankle. Okay, answers. As befitting the endovascular therapy nature of our course, a lot of people are voting for an attempt at angiography and endovascular approach. So these are the pictures, and I'd like to kind of get some comments from the panel. Has everybody got or access to a microphone? Can I go right down the line here? Josh, here you have a fellow that has a perineal artery and a dorsalis pedis artery. The popliteal is open at the knee or above the knee, but nothing really visualizes there. What are your thoughts about an endovascular attempt? Is this a guy that we might try the Safari procedure on?
Well, I think first off, I would have probably started with a CTA on the question that we had a few choices back, just because you want to make sure that you're not missing any kind of inflow, outflow lesion that you could see and would help you as far as planning your next step if you're moving towards a procedure. I will say that CT is not as good for below the knee visualization of the vessels as an angiogram. But I think
what do you think about the use of a CT in somebody with end-stage renal disease in terms of looking at the distal runoff? Do you have any comments about that? Does it have some limitations in your experience?
Yeah, absolutely. The contrast has definitely been a problem in our patient population with chronic renal insufficiency. I think we're in a situation at MUSC right now where we have kind of the next generation CT scanner that we're able to do CTA, aorto-iliofemoral runoffs with about 50 cc's of contrast with the new Siemens Force scanner. And that's definitely changed the algorithm a little bit as far as going directly to CO2 arteriograms and then runoffs in an invasive manner. But I would still start, I think, in this patient with the CT. And then once we get to the arteriogram phase, I think that I would reserve Safari, at least in this patient, until we had evidence of tissue loss, or I guess he's kind of right on the brink of having intermittent rest pain. And
well, he's got a little toe sore now. He's got a lesion on his fifth toe. So
then what you need to do is find a distal target, and based on the lateral foot, the DP looks like your best retrograde target to try to recanalize from an antegrade retrograde approach, and I think he would be someone that I would entertain that approach as a first start.
Okay. Let me go to Tom Todoran. Can you want to make some comments on interventional approach?
Yeah, I also chose actually to get a CT scan in this patient as well. And to your comment about the people with end-stage renal disease, I often find it, in spite of getting that, it helps with inflow, but the vessels are so calcified, you get such artifact, almost you'll just see the vessels come down and you can't really see any contrast. So I often don't find them helpful, but it clearly is helpful for inflow disease. In terms of revascularization, I worry when someone has one vessel runoff and accessing as an interventional cardiologist and not a surgeon, accessing one vessel to do something for if they don't have rest pain or tissue loss. Just kind of my feeling on that, because if that vessel goes down, then you take a claudicant and you turn them into acute limb. In this guy who has tissue loss, I think one important comment would be, or thing to know, is try to figure out which angiosome is involved. If our goal is to try to heal the wound, then the reality is we want to get inflow to that angiosome or that area of the foot that's being supplied blood flow. So if he has a great toe ulcer, I guess it looks like, you try to get in direct line flow into his DP.
Well, a couple of things that the panel may not be able to see it quite as well, but I think the audience can see he's got a perineal artery here as well as a dorsalis pedis artery here. Joe, do you have any comments?
Yeah, so, this on?
No, it's not.
No, as far as the CT, we almost never do CTs or MR in this setting. So as far as inflow disease, you have physical exam and you can have duplex. So if his femoral and popliteal pulses are normal, waveforms are normal, there's no lesion proximal that's going to fix his rest pain. So at rest pain, I would have done exactly what you did. Since he had intermittent rest pain, some of those patients actually get better if you just tied them over if they're frail. So I would have tried that. You did try that for about 4 months, got a little better. Now he's got a foot ulcer. So if you use the Wi-Fi classification, he's a wound 1. It's a very small lesion that might heal on its own. At most, it would need a toe amputation. So it's a small wound. It's not been infected yet, which is a big advantage. And you have profound ischemia because you have flat toe waveform. So those would kind of argue towards an endo approach. So what do we know about endo approach? Well, this is a long segment perineal and tibial disease. So if you take Scheinert series from Leipzig, one of the biggest in the world, for occlusions that are longer than 8 centimeters, the primary patency at 3 months is 33%. 33% are restenotic, 33% are occluded. So this guy, even though he's got some comorbidities, sounds like he's functional. So you could do a long segment tibial angioplasty, and within 3 to 6 months, it's probably going to be restenotic. So what I would do, if I had limited vein, I'd do a pop perineal bypass. If I had really good vein, I'd just do a pop DP, which has 80 to 85% patency at 3 to 4 years, and you'd be done with one procedure.
All right. There you have it. Like I said, there's no wrong answers on your question, so you can answer whatever you want. He underwent a SFA to DP bypass with vein. He used an in situ technique. He had 2 equal branches that branched at the level of the knee, but each took a 3-millimeter probe. There was a small adventitial injury in harvesting and exposing the vein from the valvulotome right below the knee that was repaired satisfactorily, and he underwent a 5th toe amputation, and he had a palpable dorsalis pedis pulse. So he comes back for follow-up the first time, he's doing great, and then 3 months later, right before he's supposed to see you and follow-up for his duplex, post-operative duplex, he has had great toe pain for about the past 4 or 5 days, and he comes in and says, "Doc, I was coming to see you anyway, but my toe's been bothering me a lot." And then you examine him, and he doesn't have a pulse in his graft now. His duplex suggests that the graft is occluded, and indeed, on the arteriogram, you have the same pattern of runoff with a perineal there, and there's obviously no flow in the distal part of the graft. This is a little unusual to show up at 4 months with a vein graft that's occluded, but here you go. You've got the problem. What do you think, Tom? Would you offer him anything interventional here, or he's had his chance?
Yeah, I think it's worth, in terms of, since his graft's down now, I don't know the utility of opening that up. I mean, maybe the other the surgeons can comment on that, but I think at this point, then maybe try to get inline flow with endovascular.